Hi, everyone. I just want to start by saying I have a bit of a sore throat, so hopefully I last today, but I might take a couple water breaks. Okay. So I'm here to talk a little bit about genetic testing as a representative of the Variant Curation Expert Panel for NF and schwannomatosis, and talk just a little bit about what we've been working on and why that's important for NF and schwannomatosis. Pressing the wrong one, sorry. So as I said, genetic testing. So what do we mean by genetic testing, and how do we understand the genetic variants that we find on genetic testing? So I want to start by talking about genetics in general. So if you look at the people sitting around you on either side of you, 99.9% of our DNA is exactly the same between each human, but 0.1% of us is different. And if we look within the human body, within our cells, if we zoom in to the chromosomes that we inherit from our parents, we zoom into those, every chromosome has different genes in our DNA compacted within it. Every chromosome has a couple thousand genes on it. And if we keep zooming in, that's where we get our DNA code, the A, the T, the G, and C, that makes up the alphabet of our DNA. And so 0.1% of us are different from each other and unique. The thing is, we have 3 billion DNA letters, so that 0.1% is actually 6 million differences between us. And the question is, with these 6 million differences, do they have an impact on our health or not? And so these differences, these genetic variants between any one human, the vast majority of them are what we call benign polymorphisms. So they don't have any impact on our health, they're just part of our unique makeup. A lot of those are ones that we might look to if we're doing like genetic genealogy or DNA fingerprinting, where we can see that these two people are slightly different from each other, or we can see that they're related. As we get to things that are a little bit less common, we do have some genetic variants that play maybe a small role in our health. Maybe it means that you can't drink as much coffee as the other person beside you, or it impacts a difference in your risk of getting things as you get older, like heart disease. As we get to more rare variants, we have things that might increase risk for other conditions that we don't see as often in different people. And then as we get farther and farther down into this cone, we get to our very rare variants. And these are the genetic variants that have the highest impact on our health, where having just one genetic variant might mean that you have a diagnosis of a genetic condition. For example, NF and schwannomatosis. And so when we do genetic testing, the question is, let's figure out which ones have an impact on health and which ones don't. The tough thing about this is we have not known about genetics for that long. So it was only 80 years ago that we figured out it was even DNA that was passed down from generations from people. And in 1953, we found out it was a double helix. It wasn't until the 70s that we actually developed the first test to look at an individual gene. And if anyone in this room is over the age of 35, you were born before we discovered any of the genes involved in NF and schwannomatosis. So it was in 1990 we first found out about NF1 and NF2 in humans. And that's when we actually started the very first project to sequence the entire DNA, the entire genome of a human being. It took 13 years to do it for the first time, and billions of dollars. As we got into the early 2000s, we discovered the SPRED1 gene for Leach syndrome and SMARCB1 for schwannomatosis, and later LZTR1 only 10 years ago, 2014. And then in 2015, about 9 years ago, we had gone from doing that one single genome that took 13 years in the 90s to doing 1,000 in 2015. And in 2015, that's also when we started to think about standardizing how we interpret genetic information. And so the American College of Medical Genetics, or ACMG, published these guidelines for laboratories, these different rules to help us go through genetic variants and assess them in a more standardized way. So when you think about the volume of genetic testing that's been happening, not much was going on until 20 years ago. So the top slide shows research genetic testing. And you can see there's essentially nothing happening in 2006, compared to we now have 800 million people who have had their entire DNA sequence, their entire genome read and analyzed as part of research databases. This is one particular database called GWAS that is one of the larger ones globally. On the bottom, we have clinical genetic tests, and this graph only starts 10 years ago. So 2012, very few people were having clinical genetic testing. So many people that are diagnosed with NF and schwannomatosis 10, 15, 20 years ago, genetic testing wasn't done that often. You might not have had genetic testing as part of your workup. But now within the US, we have tens of thousands of genetic tests that happen every year. So we went from a space 20, 30 years ago where we did very little genetic testing, so we didn't have a great understanding necessarily of what was common in the general population and in databases, because we just didn't have those databases. And then we also didn't have the greatest understanding of what we saw in people that had genetic diagnoses, because again, not many people were getting genetic testing done. So now we have a much larger volume of data available to us. So as an example, there was a research study done 25 years ago where they took 500 people that they knew had a diagnosis of NF1, and this is in the early days of clinical genetic testing, and they went, let's go and see if we can figure out what are their NF1 variants, what's causing their NF1. And there was one particular person, this is very small, so I'll make it a bit bigger, patient 238, they found an NF1 variant in them. And I've written it down out here. This is the address of where it was. They found this very particular change where there used to be a G, or we expected to see a G, and there was a C in that person's genetic code. And one might think, well, this was the only thing we found in this research study in this person. This must be the cause of their NF1. However, we've learned a lot in the past 25 years. So since that person was part of that research study, we have actually found that it's in a lot of people, this particular NF1 variant. If we look at the databases, probably up to 10% of people have this exact same DNA change within their NF1 gene, even if they don't have neurofibromatosis. And so though we might initially have thought that this could be the cause of NF1 for someone, this is actually one of those benign polymorphisms that's really common in the general population. And we now have software available to us we didn't have 25 years ago that shows that this doesn't have any impact on how the gene functions. So what we know about genetics changes over time based off of gathering new information and interpreting it in different ways. So what happens when you get clinical genetic testing that's done with your provider? What happens before you get that test report given to you? So you start by submitting a DNA sample. Used to be blood, now you can do cheek swabs and saliva sometimes. And that gets isolated down to just the DNA. They take out all the extra stuff from the sample. And it gets run through a machine that goes and stretches out the DNA helix, breaks it apart, and reads through the letters and converts it to a DNA code. So we get the A, T, G, C that's tens of thousands of letters long for any one gene. So they take that information, and it comes up on a computer. And because 0.1% of our DNA is different from any one person, no one person's gene is going to look exactly the same from any other person. There are going to be variations between it. And so there might be 1, 2, 5, 20 different variations that pop up in one person's gene. And we have to figure out which ones of those benign and which one of those might be the cause of their diagnosis and their disease. And so how do we do that? So I mentioned in 2015 that ACMG came up with these rules, these guidelines to kind of help guide us on how do we go through these variants and figure out what they mean. And there's 16 rules that are used to try to that give you evidence to classify something as pathogenic or does cause the disease. And then there's 12 rules that might help us figure out that it doesn't cause a disease or is benign. And I've got them summarized up here. But they look to different pieces of information. So population information, do we see this variant in someone that has clinical symptoms of NF or schwannomatosis? Or do we see it in the general population in those research databases that we now have available to us? Can we run it through some software programs and kind of predict how it works in the body, how it impacts the protein that's made by that gene? Are there laboratory tests that we can do where we can actually see the change in the function of the gene if it has this variant in it? We can also look at, does it track within a family? So if you have multiple generations that have symptoms of NF or schwannomatosis, does everyone have the same variant or not? If you are a spontaneous case, is it only in the person with symptoms in the family and not in their parents that are asymptomatic? And then do the symptoms that the person has, do they really fit that specific disease or not, which with NF and schwannomatosis, we have very specific criteria to say that you have NF1 or NF2 or schwannomatosis. For other diseases, there might not be so specific, so it's a little bit harder. But again, these rules are generic. They're meant to apply to all genes and all human diseases. But having generic rules is not always the best fit for any one particular disease area or any one particular gene. And so labs have to try their best to go through these and make them work for each gene that they're working in. And they do tests for thousands of different conditions. And so what happens is we go back to that computer that has all those variants that popped up on one person's test. And that lab goes through the ACMG rules. It's a process that we call classification or curation of a variant. And they go through all these little bits of information if they have them. Sometimes we don't know a lot about something. Maybe we've only seen it once or twice before. And in the end, they go through these rules and they score each variant. And then it comes up with one of 5 classifications. So benign or likely benign, so very unlikely that it causes a diagnosis. Uncertain, where we're kind of in the middle and we're not sure. And then on the other end, likely pathogenic and pathogenic means that we're pretty confident that it causes a disease. So one of these 5 categories that's on this spectrum. If you have a variant that is classified as uncertain, likely pathogenic, or pathogenic, that is something that's going to end up on your test report. Because benign variants are very common, we don't usually put those on genetic test reports, and also they don't impact people's health, so we don't include them. And then what usually happens once it's on your genetic test report is the lab also adds it to this database called ClinVar. Now, ClinVar is a publicly available database that anyone can access. So if you wanted to go on ClinVar, you can do that. It's through the NIH, and it's where clinical labs, researchers, other sometimes patients can also upload their data. So you can put a clinical variant and whether or not that patient has symptoms and what you think it should be classified as. So the lab will say, we decided this is pathogenic, or we decided this is benign. And this is a view that shows the NF1 gene, has a diagram that shows the variants across the gene, with the red and the orange ones being pathogenic and likely pathogenic, and then the green ones on the bottom benign. The tough thing about them is, you can see here, sometimes labs don't agree. We call those conflicting classifications. So one lab does the test and says, we think this is uncertain. And another lab does the same test on a different patient, and they say, actually, we think this is pathogenic and causes a disease. And now that is tough if you don't already have a diagnosis. So if you are a parent and your child has cafe au lait spots, and they don't yet meet criteria for NF1, one lab might say it's uncertain, and then you're wondering, does my child have NF or not? And another lab might say, it's pathogenic, this is a diagnosis. So even though it's the same genetic variant, where you get your care could influence what the interpretation of your results is. And that's the tough thing about the generic rules, because people interpret them how they feel is best. So what we're aiming, ClinVar exists within the larger organization of NIH, ClinGen, or Clinical Genome Resource, where laboratories add information, clinicians can add information. As a patient, you can add information to ClinGen through something called Genome Connect. You can upload your genetic test report, and that can be included in the databases. And you can also include information about whether you have a diagnosis or not. And then researchers, like publications, the information is added there. And the point is to bring all this information together so that we can better understand which variants cause a disease, which genes cause human health issues, and which ones have the most impact. And so that we can bring it back to researchers, labs, clinicians, and patients to improve patient care. And so I've been talking a lot about genetics. So what is the variant curation expert panel? So we come in around evaluating and improving our understanding of genomic health. And so what a variant curation expert panel does is we bring together a team of experts for a particular disease area. So in NF, we brought together people that work at the different clinical laboratories in the United States and internationally that do genetic testing for NF and schwannomatosis. We have our research labs and our researchers that work in these disease areas, the people that discovered even the different genes, like the people that discovered the spread1 gene for Leach syndrome are in our VCEP. and then also expert NF clinicians as well. And so we are spread across different parts of the country as well as different parts of the world. We have members from South America and Europe in particular. And so we go through each of those generic ACMG rules and we say, do they fit for NF and schwannomatosis or not? Do we need to modify them? Do we need to make them more specific so that if any one laboratory is doing your genetic test, they can go through these rules and they can interpret your variant in the same way in each lab? And so we go through each of the rules as a group, and then we submit them for approval through the larger ClinGen body, and then we do a pilot to make sure the rules work the way they should. So we have lots of variants that we know definitely cause NF and schwannomatosis, and other ones we know definitely do not. So do our rules work correctly for each of those? So we initially formed about 2 years ago, early 2022, and we started with NF1 first. So we assembled our team, we completed our creation of new rules for interpreting NF1 genetic variants, and then we also submitted them for approval last year. Around the time we submitted approval for NF1, we started working on spread 1 and Legius syndrome, and we're still in the process of modifying the rules for spread 1 genetic information interpretation. And then right now, we're actually in the midst of our pilot for NF1. So we have a group of bio-curators, we call them, that are going through particular NF1 variants. I think we're starting with about 16 right now. And we're going through the fine-tooth comb of that variant, asking the labs, how many people have you found with this variant? What do you know about them? Even talking to clinics, what is their symptoms? Do they fit? Do they have a family history? And then applying the rules and making sure they work correctly. And then we're planning on moving on to the schwannomatosis genes in the next year and continue working on them and getting through these 5 genes and making sure that we're really good at interpreting these variants correctly. So why is this important? We want to make sure that there's consistency between labs so that no matter which genetic lab ends up doing your testing or your family member's testing, you get the same result and it's a trustworthy result so that you know that it's accurate. And having an accurate genetic diagnosis sooner is helpful in terms of patient care. So rather than living in like a limbo of does it cause my disease or not, we can have more certainty about that. It's also helpful for family screening and family planning. Sometimes it can be hard to do testing in family members if you have what we call those uncertain variants where there's some uncertainty about whether it causes the NF or schwannomatosis in your family. But if we have that true pathogenic variant, it's much easier for us to say, yes, we're sure this is it. This is what we should be testing children for. This is what we should be testing your siblings or your parents for. Or if you are someone who's planning on having children and you're thinking about whether you want to test during pregnancy or test embryos as part of IVF, you have certainty that this is the right genetic variant we should be looking at. And this process of creating the variant expert panel also has organized a lot of NF researchers and clinicians that maybe their expertise is not necessarily in genetics, like they're oncologists or neurologists or other types of researchers, but because we're working in this group together, we've actually increased the genetic knowledge within our expert panel. So I've learned a lot, and a lot of our clinicians have learned a lot about what do the researchers do in the lab? What do the people that work at the clinical labs, how do they approach genetic testing? So we've increased this understanding. And then I think in the future, this is also going to be helpful once we get to a space where we're talking about clinical trials and drug development, where knowing your genetic variant and the type of variant and truly linking it to your disease is necessary for your access to that drug. So maybe there might be gene therapies in the future. So just want to show like who's involved. It is a large group of people that are working on this. This is our NF1 committee. So we are a large group, and when we've kind of slightly reorganized depending on the gene and what people are interested in, but we split up the rules into computational, a lot of that software and predictive rules, phenotype, the symptoms that someone has, and then functional laboratory studies. And we're led by Elizabeth Castellanos from Spain, Scott Plotkin from the Boston Clinic, and Alicia Gomes from the University of Alabama. And then this is we've rearranged ever so slightly to be our spread 1 group, but we're all working together on this. So I want to thank the Children's Tumor Foundation has been really supportive of these efforts and getting us organized, as well as the ClinGen organization has been very helpful in helping us kind of set up as a new group and learning how this process works. Particularly, we're housed within the Hereditary Cancer Working Group as our organization, the many members of the NF-VCEP and our leadership. So I'm happy to answer any questions about what we're working on and genetics in general. Thank you.
We've got about 10 minutes, so here's our first one.
Thank you very much for your presentation. Super helpful. I'm back here. Sorry. If you have a confirmed pathogenic NF1 result today, but it's from before mid-2023, or since you're in pilot, it's before all of this is about to happen, will we hear from our genetic counselor? Should we ask them to review? Like, what's the process to get it re-reviewed, or I don't know what the right language is for that. Or do we need to do that, I guess?
So the thing about pathogenic is pathogenic means we're 99+% sure that it causes your NF. So that's unlikely to change if you have what's called pathogenic as your classification. If your classification of your variant ever changes, sometimes it has to be that your genetic counselor, your geneticist, asks the lab for updates. Or sometimes the lab might issue new reports automatically. It really depends on their policy. But I think with a pathogenic variant, it's pretty unlikely it's going to change. The thing about what we're working on with the expert panel is as we, as an expert panel, go through each variant and classify it ourselves, it actually gets a special notation in ClinVar. So if you wanted to look up your variant in ClinVar, it'll actually say reviewed by expert panel once we're finalized and going through the biocuration. And when I showed that view from ClinVar where there was the filtering and the types of classifications, there's actually where you can select off, I want to look for the expert panel reviewed variant. So if you're curious if yours is one of the ones that's been reviewed by us, which we hope to review all of them, but there's thousands, so it's going to take us a little bit of time.
All right, we got another question over here.
Thank you for such a great, very clear talk. One of the things I find really fascinating about this disease is how little correlation there is between the variants and the clinical manifestations, even in the same family where you'd think they'd have a lot of other similar genes and environment. So just curious, what's the latest thinking on that? Like, what are the things that we don't know? And then also, are you guys doing research using this data to better understand that?
So yeah, especially with NF1, it's really tough. And we don't completely understand exactly why it's so variable. We are, with more genetic testing that's happening, especially more clinical testing for people that have NF1 symptoms, we are starting to learn about some of these correlations where some people that have the same variant have similar symptoms to other people. So we are actually learning that there are some what we call genotype-phenotype correlations in NF1. I think it's tough because a lot of families have unique variants, and so it's hard for us to find that. We need to find the same thing in multiple people to start making those associations. But there's probably environmental factors that play a role. There's probably other genes that are interacting with NF1 or other things within just kind of like what we call the microenvironment of our body that are influencing things, and we just haven't quite figured those out yet. But there are different researchers that are trying to better understand what is playing a role in the NF1 variability in particular, because it is so variable even within the same family. So there are people working on that.
Hi. Hi.
Thank you for waving to show me where you are.
Nice to see you again. We used to see you at NYU. If your child, I know specific, kind of a follow-up from this question here. We achieved a microarray analysis, and that was because there was uncertainty on what was presenting. And it was clear that there was a microdeletion syndrome. And we know the exact microdeletion 17q, 11.2. Is there further information that we should be seeking out beyond that level of specificity that I know not all presentation of NF1 goes to that degree?
So the thing about the large microdeletions with NF1, because that's one of the that's one of the first genotype-phenotype correlations that were discovered because of all of the variations we can find in the NF1 gene. That one is the most common because so many people have unique ones. If you know the size of the microdeletion and which genes are included, because by definition, microdeletion NF1 is not just that the NF1 gene is impacted, but there's genes beside it that are also deleted. And we do have information on, depending on how many genes are included in that there tends to be a certain association, but it's not a perfect science. We definitely have kids within our clinic that have microdeletion and adults with microdeletion NF1 in our clinic that are not what you would expect based off of the research that happened the first 10, 20 years ago when we were first talking about these associations. But you can definitely talk with your clinician about the size, especially the one that's what we call 1.4 megabases is the most common one. So that's the one we have the most information on in terms of the health risks. But even there's variability within that, just like other people that have other types of NF1 variants.
All right, got time for one more question.
Mm-hmm.
Hi, I have a child with a spontaneous mutation, and then just recently have a child that was diagnosed with a variant, a mutation of the NF gene, but it's a variant that does not cause NF symptoms. And I'm sorry, I don't know the exact mutation. We're still haven't met officially with our doctor quite yet, but just curious if you've heard of that mutation and or if you know, like roughly the amount of people that have a mutation that does not cause any symptoms. And I know the severity within NF is very great as well, so yeah.
Yeah, that's a tough question to answer without having more information. So there are probably lots of people walking around with benign variations in their NF1 gene or likely benign ones that don't cause neurofibromatosis. Someone could also have an uncertain variant, so we're not sure if it causes NF1 symptoms or not. We need more information. And sometimes over time, we talk about, I mentioned reclassification and the classification changing over time. That usually happens with those ones we call uncertain because we find it in other people. And then we have enough information to say, we're going to move this over to a more pathogenic, more disease-causing classification, or we're going to move it in the other direction. We actually think it's benign. So it sounds like it might be one of those uncertain variants or maybe likely benign variants. I'm happy to chat with you a little bit after the talk about that. But from our understanding, if it's something that's pathogenic and disease-causing, we do expect that causes NF1 symptoms in someone. I think that was the rest of our time for questions. I'm going to be up here at the front, so if anyone has a couple questions, I'm happy to hang out for a few minutes and chat. Thank you. Appreciate it.